Good afternoon, ladies and gentlemen. My name's Ian Mean. I'm Director of Business West in Gloucestershire. I've nothing at all to do with the hospital. I actually used to edit newspapers around here and in Bristol, and I'm the chairman for today. And this is all about the hospitals you want for the future. This is our fourth session. Last week, I'm told we had something like 50,000 engagements. That's people looking at this, coming into it, which is brilliant. Today, we're going to be talking about trauma and orthopedics. But before we do that, I want to introduce Deborah Lee. Deborah Lee's our chief executive here in Gloucestershire. She actually employs something over 9,000 people in our hospitals. That's the largest employer in Gloucestershire. So we know the NHS is important, but they're also a huge part of our economy. So, Deborah, I want to ask some questions. Some of them we've had before, but one keeps coming up time and time again. And that is, why on earth did you launch this consultation in the future of our two hospitals right in the middle of a pandemic?
We'll start with an easy one, Ian, won't you? It is a great question, and it's one that I've been asked before. So let's go there. So first and foremost, this has been considered really carefully. You know, we have had challenge for a number of quarters, but wholeheartedly, I remain of the view, having looked at all the pros and cons, that it's absolutely the right thing to do. So why do I think that? Well, 3 or 4 important points for me. Firstly, I believe that these changes are going to deliver huge benefits for patients. You're going to hear a bit about that today. So why would I want to delay those benefits? The pandemic of itself has created some health challenges. It's worsened existing health inequalities. So why would we want to delay anything that brings positive benefit to patients? The other thing I've heard a lot about is that staff in particular, but also local people, are anxious about what do these changes mean for them. And so prolonging it, for me, prolongs that anxiety. And there has been some concern about, can staff give their time? Is it right to bring Will and colleagues here today when they should be off doing clinical things? Well, of course, that's been a discussion, and people give the time they've got to give. But the majority of people working on the consultation are not frontline clinicians, and therefore they have got lots of time. And then I think, just to come back to this notion of the impact of the pandemic on a consultation itself, and in particular, let's name it, since we launched, we've had a 4-week lockdown, haven't we? We're in the 3rd week of it. So one thing I just reflect is that what the pandemic has shown us is that engagement has become easier. So I've stood in parish councils, town halls, board meetings, hoping that somebody would come in and listen to the fantastic stuff we're talking about. But the reality is engagement's been really poor for years and years and years, and we've tried all sorts of things to improve that. Since we went online through mediums like this, we've had phenomenal engagement, and not just from those you might think are the young, tech savvy, from everybody. We've had great engagement, regularly 20, 30 people joining a board meeting where we literally would have struggled to get one. We've looked at the 4 weeks in particular, and there were some face-to-face engagement activities taking place. And so I just want to reassure that every single one of those has been replaced. So it won't happen in the 4 weeks, but it will happen before the consultation ends. So I hope that kind of addresses some of the myths about the fact that we're not going to get a conversation going. At this point, we've had more feedback than we've had to any other consultation in Gloucestershire. And really positively, half of that's come from staff. Typically, it's 5 to 10%. Half of it's come from staff and half of it's come from the public. So people are really engaged despite the pandemic, maybe because of the pandemic.
Now, change and managing change is always difficult, isn't it? And the staff on the session today will tell us that. Is that a major issue, change?
I think it's a major issue for any organisation, but I think particularly, let's just look at the last 6 or 9 months. People have had their worlds turned upside down, haven't they? So people have had change foisted upon them, and a lot of that change hasn't felt good. It's been really difficult for people. That's impacted on how they feel about themselves, about their job. It's impacted on their ability to just keep going, in all honesty. Some people would just like the status quo to hang around for a few weeks so they can catch their breath. So it's not easy, but in all honesty, I don't remember working in NHS that wasn't always about embracing change. So I think providing we support staff and colleagues through that change, and Di will be able to talk about this later. You know, what colleagues tell us is change is okay. In fact, sometimes change is really good. If we know why we're making the change, if you involve us from the outset, and if you never stop communicating with us through that change. And we don't always get that right. We absolutely have not always got that right. So the commitment behind this change programme, because of its formality, is to do all of those things and to do it really well.
Yeah. Now, one of the other questions, Deborah, that keeps coming up time after time is the pictures of ambulances queuing up outside GRH, and patients saying, well, just how busy that is. What's the position there? What's the true position?
I thought I was going to get away with the day when we didn't discuss the ambulances. I mean, you're right to call it out. It's something that worries people. And I guess it's not just the ambulances that worry people, is it? It's this sense that that GRH is somehow overwhelmed and can't cope. And therefore, if we put more things in this direction, it'll cope even less well. So just a quick moment on the ambulances. And we've talked about this each week, haven't we? So I think people are really starting to understand this. The ambulance queuing is just the visible bit of a hospital that's under pressure. The reason an ambulance queues is nothing to do with the ambulance, typically nothing to do with the staff working tirelessly in A&E. It's because we're into a situation where we're almost one patient in, one patient out, because our bed base is so full. And in the first phase of the pandemic, that wasn't a challenge because we pretty much stopped doing everything else, didn't we? And indeed, patients stopped presenting. This time, we've said we're open, business as usual. If you think you might have a cancer, for example, come and see us. So it's great because people are. So that's, the campaign's been successful. But it does mean that this site is under a degree of pressure. But it's pressure for the right reasons. And other than in extremis, we might have 10 ambulances bunching in an hour when it is difficult. Overall, the goals we set out as a result of these temporary changes about reducing transmission, spread, doing more elective surgery, all of that we've achieved. So just a final point on the pressure thing, because it is different to these changes, is these changes are about something that's going to happen in the future. So for many of these changes, other than the pilots, one of which we're talking about today, won't happen until we've developed the infrastructure and the estate, until we've built more beds, we've got more theatres, we've bought equipment. Because you're quite right, we couldn't just drop these things in here tomorrow and cope. So this is a strategic plan. But if we don't get the plan, when the government tells us there's 5 billion quid to bid for, I want to be the trust that's got the plan on the shelf, because we've done all this consulting, and I can say, yeah, Gloucestershire's got a great vision. Let's have your money. Yeah.
One quick answer. Can GRH cope?
Under the plans that I've just described, yes, it can.
Good. Now, I want to move on to orthopedics, and we're lucky today to have Ling Kerr with us. Now, Ling, could you tell us about what you do and your title?
Sure, Ian. Thanks for inviting me today. So my name is Miss Ling Kerr. I'm one of the trauma and orthopedic consultants in Gloucestershire, and my subspecialty interest is spine surgery. So in general, the majority of the work I do is regards to treating and helping patients with spine conditions such as sciatica, spine fractures, spine tumours, spine infections. But I also look after and treat patients with general orthopedic conditions, such as wrist fractures, hip fractures, ankle fractures, and general orthopedic trauma.
And what are the plans for orthopedics? You want to create, my understanding, a centre for excellence for orthopedics. So people who have hip replacements, knee replacements, that sort of situation. What are the plans?
That's right, Ian. So we've already been on this trial of reconfiguring our services for the last 3 years. And in terms of developing centres of excellence, the plan is to have the majority of elective orthopaedic surgery done in Cheltenham General Hospital, and all the trauma surgery and trauma patients to be at Gloucestershire Royal Hospital.
Why? What can I ask you? Why would people object to what you're saying? Because isn't it right that you create a centre of excellence with the best talent and the best resources in one place? You can't have it in both places, can you?
Well, as Deborah's rightly pointed out, we do have a limitation on our resources, and we are aiming to increase the resources in the future. And essentially, there is a massive need to make our services more efficient. And that's been shown in other places around the trusts around the country. And the data we have from our trial for the last 3 years shows that we have made those efficiencies with the development of the specialist services on both sides. And that includes at least 50% fewer cancellations compared to previously. As before, for example, in Cheltenham, patients were being cancelled on a reasonably regular basis before we started this process for the elective hip and knee surgery. And then we've managed to show that we've reduced that. In addition, the volume of trauma we are getting in through our doors at Gloucester Royal is increasing day by day, and it's increased by something between 50 to 20% over the last couple of years. However, the provision of service we're giving to patients has remained steady, and therefore we've shown efficiencies on both sides and excellent patient care at both sides. Yeah.
And what about your staff? What do the team think? Are they supportive of these changes?
It takes a while for staff to get on board with changes, and as Deborah alluded to, changes are we all have to adjust to them. But in general, all of our teams, nursing, the doctors, and the other healthcare professionals are on board and are supportive of the changes we've made. I personally was a trainee in this region. I worked in both in Cheltenham and Gloucester before the changes, and I can see the benefits that we have generated. So I'm in full support of what we're doing.
Good. Thank you. I wanted to talk to Will now. Will Mason. Will, tell us about your role and what your team does.
Thanks, Ian. I'm a trauma and orthopedic consultant like Ling, and I've been the last couple of years a specialty director for orthopedic trauma in addition, which is a leadership role for a few years. And I'm specialised in hand and wrist surgery, unlike the spinal surgery that we all specialise more and more in these days.
Right. And tell us about change. I mean, it seems to me that a lot of these changes have been going on for some period. Aren't they bedded in? Aren't you already getting to the sort of centre of excellence situation?
I think it is a long journey. It's good to say that some things have been achieved. Before COVID last year in October, I think our Centre of Excellence in Cheltenham was really going at top speed. We were doing all the hips and knees, about 1,000 hips and 1,000 knee replacements a year. And unfortunately, the winter hit us, COVID hit us. But before that, we were really making good progress and reducing length of stay. And we will get back on track with that. But it is a long journey, and all reconfigurations are not something that you can achieve in 1 or 2 years. It's a longer journey.
And Ian, that's a great comment, 'cause it links to what we were discussing last week around the acute medical take. And the reason that what Will's alluding to is that when winter's difficult, we have to make choices about people that are on waiting lists and those that present at our door in an ambulance. Is inevitably the emergency medical patient takes priority and often takes beds that would otherwise be used for orthopedics. So in creating these two centres of excellence with a focus on the Gloucestershire Royal site for the acute care, allowing the likes of Ling then and Will to have protected, we call it ring fence, access to their beds and their theatres, will be great. And we've achieved that in the summer, which is good, but we've not achieved that every winter. And that's what this next phase of change will enable us to do.
Yeah. Will, one of the main things obviously is that there are many major hospitals, Birmingham, Bristol. You're not trying to be a major trauma centre, are you?
No, that wouldn't be possible. I mean, that's a national direction, and major trauma centres were made some 10, 12 years ago. We are a trauma unit, which means we deal with the less major trauma, but that's still we're one of the biggest ones in the country, in fact, probably the fourth biggest. We do about 800 hip fractures a year, and that increases probably 5 or 10% year on year. So
Yeah.
we need to modernise our services just to keep going with the increasing demand. So staying still and doing what we were doing wasn't not an option. I just want to make one point. Ling was talking about resources and them being limited, and people are probably always hearing about our resources being limited. And it's really important to understand that resource means staff. That's our biggest resource. And if you just suddenly could dump millions and millions of pounds into the healthcare system in Gloucestershire, we couldn't provide that because it's the staff. Even if I had all the money, I can't appoint another ortho-geriatrician, for example, or another spinal surgeon like Ling. They're not very frequently found.
Yeah. Just one other question to ask you. We're getting questions from people in the east of the county who say, they're quite a long way away from you. What's your position there?
Yeah, compared to what it has been, yes, I agree. There is an extra journey, and that journey time, people will be concerned about that. I understand that. And journey time for staff as well, it is extra time, but it is more than compensated for by the quality of care. When they get to Gloucester, they're going to get excellent trauma care, especially for the major injuries where we're talking about life-threatening and major disability that will be reduced.
Now, one other thing, I asked Deborah last week, I thought it was a bit of a no-brainer not to create centres of excellence, just as you've done with oncology in Cheltenham. Do you believe that's right?
Yes, we do believe that's right. It's not just a local initiative either. This has come from the Getting It Right First Time initiative, or GERF. And that's shown time again that whether you're looking at elective or trauma services that we both do in trauma orthopedics, centralising your services is the key to achieving excellence and better patient outcomes. Okay,
that's great, Will. Now, Di, can I ask you now? You're a matron, Di.
Hello.
And you're based in Cheltenham, correct?
Currently I'm the matron for the trauma inpatient services and trauma orthopedic outpatient services at Gloucester Royal. But when this pilot started, I'd just been appointed and I was matron for all inpatient services. So I led the transition from a nursing perspective. Yeah.
So you're on the front line. You're trying to. You've got a big job of managing this, haven't you?
Yeah.
How are you doing that? How are you sort of controlling people like Lynn and Will?
Oh yes.
No.
Very well.
We work really well together. So I'm part of. So Will's one of my specialty directors, along with John Mutimer, and we work as a triumvirate, and we work really well together. It's very much collaborative, multidisciplinary working within TNO. Definitely, always has been actually.
So what do you say to people who say, well, this won't work, these changes?
So from a nursing perspective, I think understandably, when this first happened, there was a lot of anxiety from nursing and therapy teams particularly, and staff were quite rightly, understandably, very anxious about sort of changing specialty, for want of a better word. I think the main concern was obviously we didn't have the services centralised. So at Gloucester Royal, as an example, we had trauma inpatient wards, plus we had an elective inpatient ward. And we had the same at Cheltenham General. We had an elective inpatient ward and a trauma inpatient ward. So centralising the services, staff understood that made sense, but understandably for two particular groups of staff, one on each site, they were incredibly anxious. So during the pilot, as I said, I was very new in post when this happened, but we made sure that we had weekly staff information sessions. We ran them at both sites. because communication is the key. It always will be, it always has been. Staff need to know what's going on, they need to feel informed, they need to be able to ask questions and raise queries and concerns. That worked really well. It was really good engagement across both sites, both Cheltenham General and Gloucester Royal, and it was facilitated by senior members of trauma orthopedics and the surgical division as a whole. So we also ran upskilling sessions, particularly for the 2 wards affected, flipping from Gloucester from elective to trauma, and then at Cheltenham from trauma to elective. We had really good input from consultants, from registrars, advanced nurse practitioners, our consultant nurses, who actually all took part, and we ran twice weekly sessions for probably about 3 months actually in total, before the switch in October 17. So we upskilled the staff. There was, I'd be telling fibs if I said there wasn't anxiety amongst the nursing and therapy teams. We give them the choice as well to perhaps move with their existing specialty from one side to the other. Not one person chose to do that, which was really actually interesting, but showed that the information and the communication and the support that we put in actually really worked and reassured our teams. And actually, we've gone from strength to strength from a nursing perspective. We've retained.
Can I just ask you, what's your message for patients? We talked a lot about the staff. What are the patients going to get out of this, guys?
So for me, it's really important that those services were centralised. So we've got centres of excellence, the elective orthopedics, beds are ring fenced, the staff are highly skilled in what they're doing, both nursing, medical and therapy staff. We run the ERAS programme, etc. And there are specific pathways at Cheltenham for elective orthopedics, and then obviously trauma inpatients. It's centralised on one place, one area, and again, it's just, for me, it's really important that you're getting the right skills, the right care in the right place at the right time with the right people looking after you.
Good, thank you, Di. Deborah, I'd like to come lastly to talk about COVID. Could you tell us what the position is at the moment with the 2 hospitals in terms of numbers of COVID patients?
Absolutely, and thankfully a very similar picture to last week. So things have plateaued. We've got 138 inpatients in our beds. We've got a few more in our critical care area. So I talked about the fact that the numbers in critical care had been very low, and they certainly are compared to the first wave, but they're creeping up a little bit. So we've got 6 patients in critical care. But again, just remember, when we had similar numbers of inpatient beds in wave 1, we had 30 in critical care. So patients are still, as I described them before, relatively well compared to the last cohort. The age and demographic remains the same. So broadly, older people that are in our beds, 70 plus. And again, touched on it last week, mortality. So the numbers of people that are dying are considerably reduced over the first wave, 12% versus 31%. So again, really positive. And that's about the treatments that we've now got access to. We understand the drugs to use. People are presenting sooner. We're testing more. So overall, a more positive picture. Obviously, underneath that is the fact that this is still a very serious illness. Even though people are surviving at a greater rate, we don't really yet understand the burden that will follow. We've touched, haven't we, before about long COVID. People are still can be really unwell even after a minor episode. So don't want to give any sense of complacency, but we're not overwhelmed. We're coping really well.
Okay, what's it like for the nursing staff at the moment?
Di, come on.
Oh, hello.
What's it like, Di, for the nursing staff at the moment?
So we're tired. We continue to do the best that we can do. This is our jobs. This is our careers. We chose to do this. We're proud to do this, and it's a privilege to be here. But it is tiring. It's relentless at the moment. But we have a lot of support from our own teams and higher up the sort of director.
I noticed also there's a comment here from Debbie Price. Deborah, it's what you've just answered. How many people in Gloucester Royal Cheltenham with COVID? You've just answered that and give us the numbers. Now, we've had some very encouraging news this week on the vaccines, haven't we, Deborah?
Yeah.
Could you tell us, albeit briefly, what the position is with the delivery of vaccination by the Trust in the future?
Yeah, absolutely. So as you're intimating, we're the lead organisation, so it's our job to mobilise this vaccine across Gloucestershire, and that's for our own colleagues, but also for the public at large. So we're well placed to do that. We're well on our way. We believe, we've been told to assume that we might start vaccinating healthcare staff this side of Christmas, and we're ready to roll. So that's, it's very, very positive news. And after Christmas, we'll then start to mobilise the vaccine for the wider public, working through the age group. So starting off with those that are 80 plus and then coming down by the decade until later in the spring, when hopefully we'll be vaccinating everybody. You've heard the headlines. There's fantastic supply in terms of the volume. We're not through every hurdle, and I don't want to underestimate that check around safety that still has to happen. But the trial data is good in terms of efficacy, so whether it works, but also in terms of safety as well. So I am personally confident that we've got a vaccine very close to being regulated and available. And as I told my kids last night, I've got a very, very lonely, bored, frustrated 19-year-old at university. He will be partying this summer. That's what I told him. Yeah, you heard it here. Good. You heard it here.
Good. Now, one last question for you. What about the government's Christmas plan? What are your thoughts on that? That's what people are thinking about today and tomorrow when we get the new tiers. This is the key thing for lots of families, isn't it?
Yeah, and it's what I'm thinking about today. It's what me and my family are thinking about today. So let me just give you a very personal and honest view. I'm not a fan of what's being proposed. I'm really nervous about what it will mean in terms of a spike in cases after Christmas. We know the lag, 14 days or so. I haven't seen my family in Bradford since before Easter. My niece had a 26-week old baby last week. My goodness, I would love to go up there and hug her and be with her. But we've had such a journey to this position. We've got the vaccine in our sights. And I completely respect the difficult decision this is for government, balancing what individuals are calling for and what the scientists are advising them. So my goodness, it's a Hobson's choice, isn't it? What am I doing? What am I thinking through? What am I advocating? Because a lot of people are asking my views on this at the moment. For me, it's all about managing risk. Yeah. So does it need to be 5 days? Could it just be Christmas Day? Do you need all three families together? Is it just a couple? If you are together, can you obsessively wash your hands and sing happy birthday? And if you've got a vulnerable family member, they should probably wear their mask apart from when they're chewing their turkey leg. So I think it's just about being really, really sensible and assessing it for yourself, because the last thing we need in January, which is our busiest month in terms of flu and winter, is what will effectively be a third spike in the epidemic. When the light is at the end of the tunnel, we can celebrate, lots of us will be celebrating Easter together. I feel really confident about that. Yeah.
Thank you, Deborah. One last message from our guest. Ling, one last message from you quickly.
Well, in light of what Deborah just said, I would repeat that and urge everyone to be very careful over the Christmas period. Wear your mask, wash your hands, keep your distance, social distancing in place when you're meeting other people in buildings and elsewhere, and still try to enjoy Christmas.
Yeah.
Hi. What about yourself? And a message for all the NHS people in Gloucestershire who are going to be working this Christmas.
I would say, I don't see my parents very often, and I'm not that far away from them, but they're in a vulnerable age group and vulnerable conditions. I really do feel very anxious, as Deborah said, about Christmas and what's going to happen. As a nurse and having lived and breathed this and currently going through it again, I would say please stay safe and please be sensible and responsible.
Thank you, Di. Will, the last word.
I would agree, and try and have fun, but stay safe, because we've only got limited resources and we're nearly there with the vaccine.
And thank you.
You mentioned our marvellous staff, didn't you? And we've talked before about the fact that, you know, we're not clapping on a Thursday. The goodie bags aren't quite as free-flowing as they were. But thank you for reminding us all and remembering that staff like Di and Ling and Will, who have been working without leave for long shifts back-to-back since before Easter, are going to do that all again over Christmas. So if you're mithering about how many family members you might see in your nice lounge at home, my colleagues on this call today won't be at home. They'll be here working, caring for people. So just a thought for them, and maybe we'll instigate a clap for carers on Christmas morning. Absolutely.
And thank you for listening and looking at this session today in association with Gloucestershire Live. And for those of you who get up early, like me and Deborah, Radio Gloucestershire in the Morning is going to be covering this. And please fill in the survey. You'll see that on the website. Next week, we're talking about general surgery. Big issue. Thank you very much.
Thank you.
Thank you, Ian.
Thank you.